Hello, everybody. If you've just joined us, this is the webinar on faith-based and private sector partnerships. Why aren't they more common? We'll be starting in just a minute. Thank you. If you've just joined, we'll be starting in just one moment. Give people a chance to sign in. Okay, well, I think I can go ahead and get started now. Welcome, everybody. Good morning, good afternoon, good evening, wherever in the world you might be. My name is Doug Fountain. I am Executive Director of Christian Connections for International Health, or CCIH. Before we get started, you can go to the next slide, please. Before we get started, you will notice a slide with instructions in French. To select French interpretation at the bottom of the screen if you would like that. So if you need to do that, please do. And next slide. So CCIH is a global network with over 100 organizations and several hundred individual members who seek to advance health and wholeness from a Christian perspective. We support this through capacity strengthening, networking, fellowship, and advocacy. We're based in Washington, D.C., but over half of our network members are headquartered in lower and middle income countries. Today, we're excited to host a discussion on faith-based and private sector partnerships. Why aren't they more common? We'll hear from Gilead Sciences, their partners, the OLA Sisters, and we'll hear from the Christian Health Association of Kenya and the Ecumenical Pharmaceutical Network. It is our hope that conversations like this will help improve timely access to quality health services for those in need by expanding faith-based and private sector partnerships. A few details for our conversation today. Please note, while this webinar is part of Gilead Sciences' sponsorship of the CCH 2022 conference, Gilead has had no input or influence into the content and participants in this webinar. Please put your questions in the chat box. So we'll be managing and looking for questions. Please put your questions into the chat box, and we'll do our best to get to them and get them answered during our Q&A time. We'll be monitoring that. I'm pleased to introduce our moderator for today's discussion, Richard Neci. Richard is the Executive Director of the Ecumenical Pharmaceutical Network. EPN is a Christian membership organization whose mission is to support churches and church health systems to provide and promote just and compassionate quality pharmaceutical services. EPN works in over 38 countries with communities in the most marginalized and remote areas where national government health services are limited. We're so grateful to have Richard as our moderator today. So with that, I'd like to introduce Richard Neci and turn it over to him from here. Richard?
Thank you, dear Doug, and hello, everyone. Good morning, good afternoon. Yeah, I'm really happy to be part of this webinar and for the opportunity to be among an excellent group of speakers. And I would like now to introduce our different speakers. And we start with Dr. Samuel Mwenda. Dr. Samuel Mwenda is the General Secretary of the Christian Health Association of Kenya, CHAK. He used his skills and passion to build the capacity of emerging health leaders and to advocate for the significant role of FBOs in delivering quality health services to the most vulnerable population in Africa. One of the outcomes of the work of Dr. Samuel Mwenda is a memorandum of understanding which have been signed between FBO health providers and the government of Kenya. And our second speaker, you will have the time to hear from Dr. Samuel Mwenda. Our second speaker is Sister Kathleen. Kate, she's a trained nurse and midwife and member of the Missionary Sisters of Our Lady of Apostles. Kate is the administrator of Bugisi Primary Health Care Center in Tanzania, which cares for over 3,000 people living with HIV. She was also part of the HIV test and treat program in Tanzania, a collaborative initiative between the Diocese of Shinyanga, Gilead Sciences, and other partners, also with the Vatican from 2016 to 2021. She often traveled by motorbike, and you have seen her in our advertisement to remote areas promoting mass HIV testing and offering treatment to anyone who tests positive. Our third speaker is Ms. Sinit Mehtsun. She's the head of healthcare systems engagement at Gilead Sciences. Sinit is a senior healthcare leader with 15 years of experience in health system design, policy research, and project management. She has worked with stakeholders in low and middle income countries to broaden access to healthcare. But also she has worked with ministries of health and finance, payers, and public and private provider networks across the US and Sub-Saharan Africa and Southeast Asia. We will have the chance to hear from our three panelists, and I would like to open our session now with some questions. And my first question will be addressed to Dr. Samuel Mwenda. Dr. Samuel Mwenda, what are the main challenges faced by CHAC? And this also may be potentially FBOs overall in improving access to care in low-income countries.
Thank you, Richard. Good morning, good afternoon. It's indeed a great joy to be a part of this panel. As you heard, Samuel Mwenda is my name. I work for the network of faith-based health facilities and programs here in Kenya called the Christian Health Association of Kenya. We are an expansive network of health facilities at various levels, all the way from communities to dispensaries, health centers, hospitals, and including some that are national teaching referral level. So through that network, there are various challenges that we experience. Kenya being a low and middle income country with a lot of economic challenges. One of the major challenges we face is resources. There's never enough resources to finance healthcare, and the cost keeps going up. There are many communities in rural areas that cannot afford even basic needs like a meal. A time like now when we have a major drought around the country. So financing is a key. The other one is human resource capacity. Either the numbers are not enough based on the services we need to provide, or there's need for capacity building, training to enhance knowledge, to add new skills as the services grow, new challenges come, or as we try to expand. Commodities are essential in delivering health services, and good quality commodities, having them where you need them, continues to be a challenge in many countries, developing countries. The other area of challenge is around technology. Technology is changing every other day. Whether you talk about diagnostics or treatment equipment that we need to use, or for information management, and therefore keeping up with technological changes, acquiring the technology that is needed, and all the support service around it, whether it's connectivity and so on. Many mission hospitals or faith-based are old. So in terms of infrastructure, it's old. There are efforts to continue renewing, improving, repurposing, and therefore infrastructure improvement becomes the other area. And the area of data management, all the way from the communities up to processing it to be able to help us make decisions is another area of challenge. Thank you.
Dr. Mwenda, I want to add to that. How have you make partnership with different private sectors to help CHAC overcome some of these challenges? Yeah. And can you give some examples of those kind of partnerships with the private sector?
Yes, thank you, Richard. CHAC, by its own nature, we are an ecumenical partnership of various Protestant churches and facilities at various levels from different geographies here in the country. So we are in ourselves a partnership. And besides that, we also have another partnership with the Kenya Conference of Catholic Bishops, where we have a supply chain organization called MEDS. So partnership is one of our key strategies that we embrace as an organization. And one of our core mandates as CHAC is to have partnerships, first of all, beginning with among the faith-based, then we have with government and government at national level, Ministry of Health, other sectors, other ministries that support health, other financing institutions like National Health Insurance Fund, and then with others who are playing a key role in the sector. Certainly faith-based, private sector are very critical in providing inputs to the health sector and the health system. And CHAC has really embraced opportunities for partnerships with private sector. And for us, we are working on partnerships at different levels. There are those partnerships that are happening right at the health facilities. And I'll give an example. And there are those that work through us to cover much of the country. And we've had partnerships with multinational pharmaceutical companies like AstraZeneca. We have one going on now with Novartis, very good partnership we've had with Novo Nordisk for many years. We have one ongoing with Africa Health Network. And there have been others, even private sector here in Kenya, like the Equity Group or Equity Bank Foundation during the period of COVID. Through this, and then Kenya has a partnership structure for the private sector called Kenya Healthcare Federation. And CHAC is an active participant in that forum because it brings the private sector involved or interested in health within the country, and together with the areas we engage government around. Now, giving some examples, we are having a partnership ongoing with Novartis. It's been there for a couple of years, but more recent times it's been expanded. And it's trying to address about 9 different disease conditions, some non-communicable, some a bit of communicable, including some complex conditions like cardiovascular diseases and diabetes, eye complications. We are dealing with pneumonia for children, asthma, breast cancer, and it has as well as a neglected tropic disease like sickle cell, which has had little attention before. It has various components. There's a capacity building for healthcare workers. There's support to be able to do awareness creation, including develop materials that we are using to create awareness around diseases. It's supporting screening of those to identify those that might have need for further attention. With screening, we do also education. They help people learn more about these conditions and how they can get assistance. Then with screening, there's linkage to health facilities. And we've created a linkage or a referral arrangement from lower level to more specialized facilities where some of the other services are provided. Then there is the support in the area of technology in some of the higher level facilities for diagnosis, and then for treatment is a major component of access commodities. And for us, the other beauty about the partnership is that it has also involved Meds, which is our supply chain organization, one of the leading supply chain organizations here in Kenya. And therefore, the commodities, a variety of molecules, different types, addressing the various disease conditions, we are able to access them through Meds. And it's supporting the whole area of data collection, data management, so that we have evidence in informing how we are performing, as well as any strategy for improvement. Another one I can mention very quickly, because a little different, very unique, is with Africa Health Network. This is an organization from the US. We are currently partnering in establishing renal treatment centers in the country. We are on the 5th one. In fact, at the end of this week, we are opening one. They are helping us set up dialysis units, very well equipped with, they help do infrastructure. We set up the units, including the water treatment systems, and they bring in trained staff, set up the information system, bring in supplies, and we have an arrangement of getting that service self-sustaining. We are getting a lot of clients, covered with the National Health Insurance Fund, and it is providing every hospital like 10 to 15 units of dialysis, and they're becoming centers of excellence. And not only for providing the service, but also training and areas where others can come, have mentorship, have training, and so they can go in to serve in other areas. Thank you.
Very interesting, Dr. Samuel Mwenda, how you are advanced in partnership with the private sector. So we'll come back to you, but let me address my next question to Sister Kate. Sister Kate, can you tell us a little more about the Tanzanian Test and Treat program, and how did Gilead began partnership with all our sisters? And maybe you can also add, why was the partnership successful?
Thank you. It is my privilege to be here today. Our network isn't that good, so please tell me if you can't hear me well. Mm-hmm. First, I'd like to, you've asked me 3 or 4 questions together, so let me go slowly. The Test and Treat project was an innovative partnership between the Vatican in Rome and Gilead scientists. And it aimed at closing the counseling and treatment gap by implementing free universal HIV counseling and testing, and providing access to free care and treatment to newly diagnosed HIV patients in the rural areas of Tanzania, namely Shinyanga and Simuya region. And to implement the project and to enhance the already existing services on the ground, both the Vatican and Gilead teamed up again in partnership to join forces with St. Stephen's Aid Trust in Chelsea, Amsterdam Institute of Global Health Development, Doctors with Africa Kuam, the Diocese of Shinyanga, and us, the Ola Sisters. And then we had close collaboration with the Ministry of Health in the area, the National AIDS Control Program of Tanzania. And they ensured alignment with WHO and Tanzanian national guidelines was always to the forefront of the project. I think the program's success is a result of enduring, innovative, multi-sector partnership, working together in a spirit of collaboration, and above all, a passion to improve the everyday life of people living with HIV/AIDS. The teamwork therefore enabled access to HIV counseling and testing for up to 340,000 people over the 5-year period, and quickly connected 3,929 newly diagnosed HIV patients to care and treatment. And almost 100% of pregnant women who were diagnosed HIV positive, and when they were admitted to delivery, had already started ART, antiretrovirals, thus preventing mother-to-child transmission. People in the catchment area of Shinyanga and Simuya adopted HIV preventive practice. Many of them were aware of their HIV status. There was an increase in the number of patients on antiretrovirals, and the viral load suppression was that was reduced, and as a result indirectly prevented HIV vertical transmission. We also, a big part of this project was they introduced us, all the partners introduced us on the ground to differential service delivery, in which we set up club models based on decentralizing HIV care from the hub level out to the community. And then where I'm working in Bugisi, it's a rural village in Shinyanga rural, and we have 38 clubs with 850 clients attending for services. You know, before this project came in 2017, we had 2,072 patients people living with HIV under our care. And then by the end of the project 2021, we had 3,116. And, you know, the project, they helped with an awful lot with infrastructure, with professional staff. You know, in a remote village, it's the missionary that will always go to the remote village where nobody else wants to go. But it's very hard to get professional staff, and especially to get doctors. Now, 2022, we have two medical doctors working here, and clinicians, and over 20 nurses. So it's a huge difference to our services. The care for the patient has really, really improved. I hope I've answered your question. Thank you.
Very good. Yeah, this is a very good case of how the partnership can reach out to patients and increase access. And now one final question to you, Kate. What are some lessons you learned, and which recommendations can you provide for future of partnership between faith-based organizations and private partners?
Okay, in remembering lessons learned, I'm reminded of an African proverb. If you want to go fast, go alone. If you want to go far, go together. This describes for me the importance of partnership with multi-sectors so that we can go far and go to the last mile. I think now more than ever it is the time for public and private companies to join with FBOs like faith-based organizations, to serve a social purpose. A multi-sector partnership with all sectors involved will have more effective results when people within the partnership come together with the view that they are in it for the long haul and not in competition with each other, that they are prepared to give of their time, their talent, their creative thinking, their efforts, and then pooling of resources. And those moving and leading these multi-sector partnerships need to trust in God and trust the process and the process of networking. And from my experience, the shift is profound, and real positive results and real positive change will happen. I have experienced it firsthand in the Test and Treat project. And then my second point is every sector can and should play a role in the community health. We don't need to feel tied to traditional spaces or roles. Differential service delivery is a person-centered approach that adapts HIV services to the needs of people living with HIV and also reduces the burden on the health facility. Our Test and Treat approach has enabled us to maximize the resources that we have in the rural community by shifting the responsibility for HIV screening and care away from a small number of specialists to more available and abundant like nurses and community health workers. We have been able to expand our reach, slow down transmission of HIV, and strengthen the health and well-being of our community. So that's it.
Great. Yeah, very, very interesting to see how the partnership supported and helped you to reach out the last mile. And thank you for this statement, trust in God and in the process. I like this one. So let me go to to Sinit. Thank you, Sinit, for being part of this from Gilead Sciences. And I have two questions before we move to the next session of questions. One is how our partnership with faith-based organization and is different from those with government and other private sector health providers, in your perspective as Gilead.
Great, thank you so much, Richard, for the question. And again, so excited to be able to participate in this panel. I don't necessarily know if I see them as very different. I mean, a lot of the principles are the same. For us, in what we look at for FBOs, we see them, that they're a critical part of the community in ways that we, as the private sector, simply are not and will never be. We know that faith plays a very important role and a specific role in people's lives, and faith leaders are great conveners and messengers that are able to meet community members where they live and in their everyday lives. We also know that faith-based groups are uniquely positioned to care for their communities. They are often seen as the glue for rural communities or the fabric of communities. And not only do they provide a space, of course, for faith and belief, but they are connecting community members to each other, but also to resources, healthcare, opportunities, and also different types of employment opportunities. They really are the fabric of the community. So for Gilead, we know that we need to listen and learn from the communities that we serve. And faith-based communities are communities that we learn a lot from. I mean, you heard Sister Kate just speak to our partnership in Tanzania, and that is one of the most enduring and impactful partnerships that we have at Gilead, working in Tanzania. So we really kind of understand the importance and the significance of this community and to be able to reach people that are really underserved.
Good. Can you also tell us what are the strengths of Gilead? Those which help you to be good partners with faith-based organizations. What are your strengths?
So in Gilead, we have been in the fight against HIV for nearly 30 years. And what we've learned in the process is that it's not just about science and innovation. It's about partnership, which we've heard the other panelists also speak to. And the approach for partnerships is really around communities, engaging with communities that are impacted by HIV, centering discussions around communities, listening first, understanding the realities, and working together to address our common goals in expanding access to health and wellness. And so we don't just come with the science and the innovation. That's not enough. We also have this core value of centering around communities. And this is the approach that we take in our partnerships. And this has really, as you heard Sister Kate speak to, is the core kind of value around our collaboration in Tanzania. Thank you, Richard.
Thank you, Sinit. Centering to community, and the Church Health system is really keen in working with the community. So let me come back to our last round of questions before I open the floor to questions from participants. And I would like to ask this question to all our three speakers. And we'll start by Dr. Mwenda, and after Sister Kate and you, Sinit. And one of my questions would be around why do you think this partnership? I heard from Dr. Mwenda that recently they started partnership with Novartis. So why do you think such partnership between FBO and private sector are still relatively uncommon. Dr. Mwenda, are you there to? Yes.
Yes, Richard, I'm here. Thank you for that question. I think it's both from our side as FBOs and from the private sector side. For us, traditionally over the years, we've seen private sector as a sector that's interested in business. So whatever they drive, it's the motive is business. So and for us, we are faith-based. We are committed to providing social services, charitable social services, and targeting the poorest who probably may not have any means to purchase what the private sector has. But I think what we've learned over time is that no, it's not us versus them. I think there's a lot of areas where we have common ground. Private sector is very good at developing innovations, and a lot of these innovations are well informed by evidence, by research, and some of the innovations they have are actually very appropriate for even the last mile, helping us to reach the completely unreached. When we look at what private sector is helping us do here in Kenya, for example, in the area of technology and communication, it has totally changed our way of life. Given what we're able to do with our mobile phones. So we also realize that a lot of the products that we use are actually produced by the private sector. So how can we encourage private sector, even from the highest level, to put aside some of their expertise and resources to come and partner with us, who are so committed, who are on the ground, who have networks, who have systems that can be depended upon, to help deliver whatever products and innovations that they have to help those that have not been reached. But also, some of the faith-based have quite well advanced systems. Like I mentioned, the supply chain we have in Kenya called MEDS. They are able to entrust us with their commodities, essential drugs, which we are able to distribute to wherever they are needed, whether it's private, public, or FBO facilities. Thank you.
Thank you. Sister Kate, can you also respond to the same question?
Thank you. Before 2017, I would have said, yes, they were relatively uncommon. I'm going to speak from my own experience. And so from my personal experience, these partnerships are not uncommon. We as OLA sisters have always worked close collaboration with the local Tanzanian government authorities on a local, district and regional level. And they have introduced to us a lot of groups, like, for example, THPS, Tanzanian Health Promotion Services, Rafiki, Baylor, a lot of NGOs they have introduced to us. And we have, because we're an international congregation, there was always people in Ireland who always supported our mission, but on a smaller level. And then when the test and treat, we shared partnership with them, it kind of opened it to a bigger scale. It allowed us to develop and to help many more people. So we also work with local churches, with dioceses, with volunteers. Like every year we have volunteers coming from many different countries. Like we have volunteers coming, because of the project, it has come from, volunteers have started to come from China, Japan, Holland, and the US, which we wouldn't have had before. We would have always had volunteers from Ireland. But they have always come, and I think there's a greater social consciousness among the private sector, and many in that want to do and to help. I think they're passionately committed to working in partnership with us, and they want to put their commercial services to the good. And I think we're on the ground as missionaries. We'll always go the last mile, because that is what we are called to do. So, and I think with their support, and a lot of in the private sector are they're very experienced, they're very professional, and we are professional as well. We are religious, we are professional, but you have the brightest minds in this. So when you can get them on board, you can make a huge difference to the service you provide. Thank you.
Very good.
Yes. Sorry, 1 sec. I would like to say, just as interest in our small village, in a remote village in Tanzania, we have Gilead are supporting us. We have the Tanzanian Health Promotion Services are in partnership with us, Rafiki, HPON, the Glazier Foundation, and the Neci Foundation. So there's many different organizations coming in because of the partnership with Gilead. Thank you.
Okay, I think Sinit will say the same thing. It's not uncommon. What do you think, Sinit?
Absolutely. I would say the same thing. I would even go as far as to say, we've heard in this panel, we've heard Sister Kate and Dr. Samuel talk about the services that are being provided by FBOs in Africa. Significant. If we don't partner, we will never reach our goals of broadening access. So for us, I mean, there's no other option. This is a critical element for us to reach our goals. And those are around broadening access to quality healthcare, centering communities, like I said earlier, changing the paradigm where we put community voices at the forefront and are responsive to the needs of those with the same lived experience of living with HIV. And then the third is this issue of stigma and decreasing stigma. And if we don't work with FBOs in these areas, we will never reach people and curb the death of this epidemic.
Yeah. I think also the pandemic has been a lesson for many of us as FBOs. ZPN in the past, we could not partner with a pharmaceutical company directly, but we realized that we cannot go far if we don't partner. And the pandemic showed that all of us should play a role, a key role, and coming together, as Sister Kate said, we will go far. So thank you for that. Now I would like to open the floor to our participants. I've seen already many questions in the chat box, and we'll begin with those already in the chat box. And I would like to request our speakers, if you can also respond to some of them directly in the chat box as we are moving forward. I can see a question from Salim, and she would love to know the importance of such partnership, especially with all our sisters in Tanzania, in solving health challenges in East Africa. Which specific health challenges are being tackled? And please, can you explain why faith-based and private sector partnerships are not common? So I think it's part of what the part of the question has been already responded to. And yeah, Sister Kate, would you respond to this?
Sorry, just give me a sec.
So the question is,
yeah, sorry.
The question from Salima. She's asking, she wants to know the importance of such partnership. I think we have responded partly to the question, especially in solving health challenges in East Africa. Which specific health challenges are being tackled?
I'll just answer the first part of it first. I'm going to go back to, I am 22 years in Tanzania, so I'm going to go back to an African proverb. A rooster is not expected to crow for the whole world. So therefore, you cannot expect faith-based organization and religious congregate to carry the majority of the load. So they must be seen as critical partners in reaching and caring for the vulnerable and those on the periphery. That is our call. That is what we are called to do. So if in any area of health, those on the vulnerable are on the periphery are not cared for, it's our responsibility. But we shouldn't be expected to carry the load. We work in partnership. That's with private, with public, and with government. So that's the first part. The second part, the second question, sorry. I can't see the questions up here.
Yeah, the second question was about, can you explain why faith-based and private sector partnership are not common? So for you, you said it's common, so this is not for you. Let me take the second question. Thank you, Kate. The second question is from a participant from TIA Found DRC. What are the mitigation measures CHAC puts in place to face the challenges which Dr. Mwenda has been presenting? Dr. Mwenda, what are the measures? You have talked about a number of challenges.
Thank you. Health sector anywhere has challenges, and we start by recognizing them, trying to define them well, understand what are the root causes. And then we do planning. As an organization, we have a tradition of doing strategic plans. We do operational plans. And every time we are reflecting on our challenges, also looking at the context, what strengths do we have, what the weaknesses that we need to address, but also what opportunities are out there. The next thing is really to look out to partners that we can collaborate with. There are those that are funding partners. So we reach out to them when the opportunity to present proposals for grant applications. We do that, and we have some significant grants that we are privileged to run or to manage from partners like USAID, CDC, PEPFAR, from some of the pharmaceutical companies in the private sector, from faith-based organizations, from foundations. So when those opportunities are available, but we are continually engaging government. Primarily, the governments have a responsibility from the constitution. The constitution of Kenya obligates government to provide for its citizens. But we know the government cannot never make it alone. So where we feel that the government can offer support, we are continually engaging in advocacy, articulating issues that need to be addressed, areas where we can get support, areas where we can better collaborate, areas where they can extend some capacity building, opportunities, system strengthening, or public health commodities. We also try to do the same with development partners who support the health sector in Kenya, whether through commodities, through training, or their projects that they are supporting. Then we're encouraging these partnerships. And then although health workers will never be enough, we have community health workers, and we're trying to build capacity, mobilize, utilize community health workers and volunteers to help us at the community level. Being mobilization, awareness, some services at that level, and also helping people link up for services. And then finally, the other thing I can mention is the insurance, particularly where we have social kind of health insurance. And because the premiums required to join that scheme are quite modest, and it is possible for many people, but they need to be educated. They need to be empowered. They need to be encouraged and shown how to join and sustain their membership. So Kenya, we have the National Health Insurance Fund. Like for the dialysis unit that I mentioned, most of the users of that service, all they require is to pay, I think it's $60 in a year. And with that, they're able to access dialysis at least two sessions per week for life, for throughout the year. And the fund pays for it. And what the fund is paying is actually adequate to sustain the services. So looking all around where there can be a way to collaborate, to partner, to link, including how to empower people to best allocate the resources that they have, including for health. Thank you.
Thank you, Dr. Mwenda. There is a question here from Harriet Makweta. She's a journalist from Mwananchi, Tanzania, and she would like to know, in the context of the ongoing efforts by Tanzanian authority to roll out the universal health coverage insurance schemes and laws, is there a way such partners and innovative approaches to reach more people could contribute towards the country's effort? They want to know if this is maybe Sister Kate, would you be able to respond to this because it's specific to Tanzania?
I think I'm only familiar with the experience in the area that I'm working in. If I can pass it on to my fellow panelists. I know it concerns Tanzania, but I don't know enough to answer that question. Sorry.
Okay, Dr. Mwenda, maybe you can also, you have an experience on working with the government. And the question is, in the ongoing efforts by different authorities, maybe not only in Tanzania, in Kenya as well, to roll out the universal coverage, and you have talked about the insurance schemes. Is there a way such partnership and innovative approaches to reach more people could contribute toward the country's effort?
Yes, I think I can share from the experience in Kenya. I've been very involved in the health insurance that is more social, the National Health Insurance Fund, including some reforms that we've been trying to work on. And I can definitely confirm that you cannot achieve universal health coverage without partnerships. And it has to be partnership from at all levels and bring on board everyone as much as you can. Even including when you have health insurance. Unlike where you have a mandatory one for people who are in employment and you deal with the employers through law, where you're encouraging the communities to join a scheme to put a bit of their savings into a health insurance scheme, whether it's at community level or it's one that's managed by government at regional or national level, people need education. People need, information. Awareness is needed. They need to be guided how they can join. They need to be educated on the benefit of being part of a scheme, putting your money aside for health and how it works. And they need to be empowered, to get registered, to get the identification documents, to keep them active, and also how they can choose the facilities they need to go to, and if there are processes required there. We've seen there's a lot of processes there, and you can have either partners in communication, partners in health financing, partners in public health, those who manage information, those who are in advocacy. There's a lot there. There can be those who just help for the very poor, the indigent, to help those families pay the little premium, the premium that they're required to pay. We are doing that, a lot of that at individual level, in our family, to our families and people that are needy in our programs. But also you can have a partner who decides for this, very desperate community, I will choose to take care of this population. The other element is probably in the technology. How can we assist maybe in using communication, using media, using social media. And for those of us, I hope the scheme in Tanzania, as it develops, it will be like Kenya. Now we are able to access our scheme through our mobile phones, check the status of our registration, but also make our monthly contributions. So from wherever we are, we can pay for our old folks in the villages using our mobile phones. We don't have to, move around. So in the entire system, including the system for managing the scheme, there's a lot of knowledge and innovations that the private sector can make a contribution. Either you are a funder, you are supporting capacity building, or you are helping certain communities, even build an advocacy capacity to be able to engage their leaders and the others. And for us at Faith-Based, because we have presence to all the way to the communities, I think we are a good partner to work with. Thank you.
Thank you, Dr. Samuel. There is one question, maybe before I come to the question from Full Friend. Mr. Chisenga or Miss Chisenga Mkunda is asking if this meeting is for Tanzanians only. No, it's not for Tanzania. It's for our member, CCIH members and partners all over the world. So we are not here only for Tanzanian, but we are taking this example of Tanzania partnership, private and public partnership, to see how we can advance this very good model of partnership. So from Full Friend to Sister Kate again, there has been challenges with retention with the test and treat strategy in HIV. How did the organization overcome this? Can we say it's the partnership that gave this success? Sister Kate. You are muted, yeah.
My apologies, yeah, I'm sorry, just a second.
Yeah.
I agree totally. Starting patients on antiretrovirals is just the first step. Keeping the virus fully suppressed, and it's far more complicated, and to keep them in therapy for the remainder of their lives. And the government of Tanzania have always been a support to us. They were conscious in our village that we have many patients, 3,116 under our care in a small health facility. So they reinforced their support. They provided another NGO to help us, especially with loss to follow-ups, if we lose patients to loss to follow-ups. And we have a team that are full-time going out to the village, going after anybody that has lost a follow-up or the reason why. And that's why if a patient becomes stable, we try and let them enter the clubs so that they're near home to get the treatment, because many of our patients are coming 2 hours to get to our facility. They can go to others, but they have chosen to come to us. But it is a challenge, but we have a team and we constantly review every month who we have. And if a patient does not turn up for clinic, they immediately they ring them and see them come the next day. And then if they don't come within the week, they go to the village to meet the patient.
Yeah.
Is that answering, I hope?
Yeah. Thank you, Sister Kate. There is one interesting question for Sinit. And I think this is one of the kind of question which we receive time to time when it comes to work with a manufacturer, pharmaceutical manufacturer. And the question is, why is Gilead keen on FBO partnerships? What's in it for them as a for-profit company?
Thank you, Richard. Yes, this question does come time and time again. And for us in our group in Gilead, we have commitments to health equity and to access. And we want to be able to reach the communities that are underserved and that are often neglected, which is why we've partnered with the Ola sisters and Sister Kate in addressing and tackling the specific issues. So again, it's not just about medicines, it's about health system strengthening. We heard Dr. Samuel talk about capacity building, about training, and these are the things that we partner with to help contribute to building the health system as partners based on the goals that are set out by governments and by ministries of health. So we contribute to ongoing reform processes, and we care about reaching people that are underserved. We care about broadening access to quality health services. We care about, like I said, centering on the community. So, we're really trying to show and demonstrate that through these types of partnerships, that we're really serious about putting action behind our health equity commitments. And this is why a role like mine has been created in this organization, looking specifically after health system strengthening, after health equity. I have a background in public health. Before coming to the pharma industry in the last 5 years, I was in public health working in different NGOs. So, we're changing our processes, we're changing our approaches, and we're evolving and we're learning. But COVID is also another accelerator. We need to think differently about access, and that's why we're here. And partnering with FBOs is the only way to reach those that are often forgotten. And we can't do that ourselves. We have to partner with the people that are doing the hard work, the invisible often work, the work that's really, going, like Sister Kate said, from village to village, checking on people, finding out where they are, why aren't they in care? And, that we recognize what we can bring and we recognize what we can't do. And we have to collaborate with partnerships to be able to do this together.
Yeah.
Thank you for the question.
Thank you. I think we have another example. Doug from CCIH connected one time EPN with Novartis, and we started the partnership, Novartis, without any direct experience in AMR. They said we can work together, leveraging on your experience and have impact in the community. And we are running a very successful project in 3 countries around AMR. So I think it's good when we see even pharmaceutical companies also leveraging their systems involved in public health to support and reach the community. I think this is the best way.
And just one more thing to say,
yes,
we have to build trust. And how do you build trust? You go, you have the hard conversations, sometimes the friction, but then you stay and you don't get discouraged, and you stay and have sustained dialogue. And this is what we did with Ola Sisters. We have a long sustained partnership over time, really working on a shared goal. And that came through so much dialogue and faith, like Sister Kate said. So this is the challenge. It's building trust, and you do that, one step at a time.
Yeah, let me ask, our time is really running quickly, but I've seen a similar question from Faustin Sambe. It's in French. He's saying, comment parvenez-vous à conduire un plaidoyer conjoint dans la mesure où certains sont lucratifs, d'autres non? In English, how do you manage to carry out joint advocacy insofar as some are lucrative and others are not? How can we jointly conduct advocacy when we are not on the same level? Some are lucrative and others not. Can you? This
is to me. I'm assuming. Yeah. I think what we focus on with advocacy is the evidence base around implementation science. Here is what works in different models that we are testing and we are bringing as global public goods to inform, like we've talked about in this discussion, policy, to inform different choices, to help guide different decisions. So this is where we focus on advocacy. It's not about anything else. It's about the evidence base of what works in patient-centered care and decentralizing care in reaching the most vulnerable. This is how we approach advocacy from the industry, from Gilead.
I'm sorry, our time is really finished, but maybe the last question before I hand over to Doug. My last question, which comes from Mr. again, Faustin Sabe. More often than not, the information system is fragmented between the faith-based and private sector. How can they manage to use their data for learning and conduct data-driven interventions? Yeah, around data. So, Dr. Mwenda, can you respond to this question about information system, faith-based, yes. Private sector?
Thank you. Yes, we all generate data as we provide services. And In many of our countries, Kenya included, we have an obligation to report to the Ministry of Health database called the DHIS2 or Kenya Health Information System. And that data is actually available. The private sector is also supposed to. They are working to improve on that. The other way is at the level that we choose to partner or to share lessons, engage together, that we bring our own information and experience and data as we sit around the table to engage. Certainly for Kenya, I think there's a good example. Faith-based, we have a platform. We call it the Kenya Faith-Based Health Services Consortium. And for us, we have a way of working, and we have secretariats that are able to generate data and information as required. The private sector is also quite organized in Kenya. Overall, we have the Kenya Healthcare Federation, but we also have other smaller subsectors like Kenya Hospitals Association, Kenya Rural-Based Health Hospitals Association, and so on. So within those formations, they are able to generate whatever information and data that is required. But usually we find this engagement, it has to be purposeful. What are we coming together for? I know, for example, since the year began, we have been very intensely engaged together, advocating and negotiating with our major health financing insurance, the National Health Insurance Fund, on costing of essential packages, because they are providing them, we are providing them, and we have found it necessary to get together with evidence about what the costs to provide service in a faith-based, the faith-based facilities at different levels, and what is the cost in the private sector. And using that, we sat on a round table with the insurer, and we've had very, very progressive discussions. So what I found, yes, how do you get yourself together? Number two, what's the purpose for the engagement? Number three, so what data and evidence do we need? The private sector at the higher levels tend to be a lot more endowed in terms of technology, systems for automated data. I know we have that also, working on that progressively as FBOs. So this can even further enhance efficiency in pulling the data, the information that we need at a particular time. And we can learn from each other. We can share platforms, but also we can share lessons, including on systems that best work. Thank you.
Thank you, Dr. Mwenda. Thank you to our speakers. I would like to hand over to Doug. I think the conversation needs to continue. And yeah, Doug, please let us conclude.
Right. Well, thank you, Richard, for guiding us through this time. We really appreciate that, and for the contributions of each of our speakers. We've really heard today that FBOs and private sector partnerships are more common and innovative than we previously thought, and the universal health insurance schemes may be accelerating our opportunities. I like what Sister Kate said, that it starts with recognition of a shared passion. And I like what Sinit said about understanding the importance of community engagement. We know that sometimes partners speak using slightly different terms or work on different timelines, and that each brings different resources to the table. And that's where the work of networks, frankly, like EPN and CHAC and others, work to improve the chances of success for partners like what we heard about today with OLA Sisters and Gilead. We're so grateful for our speakers, for Gilead's support in initiating this conversation, and for our audience participation, which is excellent. This webinar was recorded and will be posted on CCIH's YouTube channel. You'll receive a link in an email from CCIH. With that, I really thank you all, really appreciate the time. Wish you a blessing for the rest of your day. Thanks, everybody.
Bye-bye.